Let's discuss a hematology case. So we have a 65-year-old male with widespread erythroderma, intense pruritus, and generalized lymphadenopathy. He also has a history of chronic eczema-like skin rashes that have progressively worsened over the past 2 years. A peripheral smear is performed in the patient, and what you can see are these cells, clearly abnormal, okay, with multiple indentations. These cells are Sézary cells. Sézary cells are cerebriform looking cells. You can see with all these indentations and a few indentations over here, they are cerebriform cells which resemble the sulci and gyri of the brain. Okay, so these are the cerebriform cells, and the diagnosis could be Sézary syndrome. However, how will you say? Will only peripheral blood cells showing these features sufficient to call it Sézary syndrome? No, the answer is no. Sézary syndrome is usually a triad where you're going to see generalized lymphadenopathy, okay, and you're going to see cutaneous lesions, mostly generalized erythroderma, okay, and Sézary cells in the peripheral blood. So you need to see all these three features, and we will see cells which are clonal, and these cells which are present in each of these regions should be clonal T cells, especially clonal CD4 positive T cells. Okay, so only then it would fit the criteria of Sézary syndrome. Now let's look at the flow cytometry chart for the same case. Of course, there are CD4 positive cells, which you can see here, and these cells which are CD4 positive are CD8 negative. So the T cells are CD8 negative. Apart from that, what you can see here is the CD4 positive cells, again when tested for CD7, they are CD7 negative. CD4 positive and CD7 negative. Similarly, you can observe that there is CD4 positivity and CD26 negativity. Okay. So what is the criteria of diagnosis? A minimum of absolute Sézary cell count should be about 1000 mmQ, and expansion of CD4 population with a ratio of CD4 to CD8 more than 10%, as in this case, and a loss of at least one mature T cell antigen, either CD2, CD3, CD5, CD7 or CD26, in association with the increased lymphocyte count with evidence of a clonal CD4 positive population, which is determined by flow cytometry. Okay, so this is the criteria of Sézary syndrome. Also remember, Sézary syndrome may not always be a sequel of mycosis fungoides. In mycosis fungoides, you might see generalized lymphadenopathy, you might have erythroderma, but in mycosis fungoides, you will never see peripheral blood showing Sézary cells. Okay, at least not more than 1000 mm. Right? So this might go ahead and mycosis fungoides may progress to form Sézary syndrome, or Sézary syndrome may occur de novo also without the presence of mycosis fungoides, underlying mycosis. The treatment would be extracorporeal photopheresis. So what does extracorporeal photopheresis mean for Sézary syndrome? The whole blood is centrifuged and leuco-enriched blood plasma is produced. Now, 8-methoxysuranin is added, which is an additive to enhance UV light action, and then UV light is applied, which will destroy these abnormal T cells and which will result in reducing systemic side effects. And now these will again be sent into the patient's body. So this will reduce the systemic side effects. If the patient has a mycosis fungoides, a localized disease, so a targeted therapy can also be done. Targeted UV therapy can also be done in the particular area. Okay, so this is the treatment. Now let's go back to the question. A 65-year-old male, we know widespread erythema, intense pruritus, and generalized lymphadenopathy, history of chronic eczema and rashes, right? So flow cytometry will show which of these characteristic findings. We know the answer over here is B. CD4 to CD8 ratio more than 10 with loss of CD7 and CD26. Now, what would be A? A, whenever you have a CD4 CD8 ratio less than 1, that means CD8 ratio is more. CD8 ratio is more, and increased CD8 will be seen in cytotoxic T cell disorders, which are associated with increased CD8. I have a list, I'll show you. And then predominantly B cells with 14 and 16 expression will be seen if uh, the abnormal cell was a monocyte, because 14 and 16 are monocyte markers. And the dual positivity of CD5 and CD23 in atypical B cells, if they were atypical B cells, and a dual positivity of CD5 and CD3 would indicate that this is a case of CLL. Okay, right. So let's see what are the typically CD4 positive and CD8 positive. So this will give an idea. CD8 positive are aggressive epidermotrophic T cell lymphomas, lymphomatoid papillomatosis, which is usually CD8 positive, primary cutaneous gamma delta type lymphomas, subcutaneous panicleitis like T cell lymphoma is also CD8 positive. CD8 positive acral T cell lymphoproliferative disorder, as the name says, is CD8 positive. However, CD4 positive mycosis fungoides including Sézary syndrome, lymphomatoid papillosis type D was CD8 positive, A to C is CD4 positive. And then primary cutaneous CD30 positive ALCL is typically CD4 positive, and CD4 positive small or medium type lymphoproliferative disorder is also a CD4 positive lesion. So these are the differentials you need to know about CD4 positive and CD8 positive lymphoproliferative disorders. Thank you.